invite Abha to give concluding remarks on the whole webinar because she is the international convener. So Abha will conclude the webinar and you will conclude the panel. Yeah.
Thank you.
Ranjit sir, are we live on YouTube?
Yes, we are.
Vishal sir, we are live on YouTube. I am starting the recording.
Okay.
Just a sec. Yeah, we are live on YouTube as well as you started the recording. Vishal sir, you can start.
Vishal, you stop a recording. I will stop at my end recording. As a co-host, I can do that. So you stop recording.
Stop.
Vishal,
Ma'am, I have started the recording. You can stop it as a co-host.
Okay, okay. I will stop and I will.
At the end where it is required, you can do it, ma'am.
Yeah.
Vishal sir, you can start.
Good evening, everyone. I am Dr. Vishal Bhane, working as a Senior Manager Medical Services at Walter Bushnell. On the behalf of the company, I take this opportunity to welcome you all for this live webinar on early pregnancy problem. I will not add too much and request Dr. Jyoti Malik, Medical Superintendent of JJ Medical Institute at Ballabgarh, to proceed with this session.
Thank you, Dr. Vishal, and thank you, Walter Bushnell, for giving us this platform to interact with our foreign faculty and to exchange the ideas and welcome all delegates to this Indo-International Web Series 8 in association with RCOG India License Group. And today we are, our topic is early pregnancy problems. And on this good, warm Saturday evening, I welcome all of you on this wonderful platform. And at the outset, I would like to introduce our conveners for today. As usual, Dr. Lakshmi has been the convener, and our foreign convener today is Dr. Abha Sinha. So I hand over to Dr. Lakshmi to introduce our coordinators for today, our international and the national coordinators, and also to welcome our foreign faculty today on this platform. Over to Dr. Lakshmi, ma'am.
Yeah, thank you. Thank you so much, Jyoti. We have started this Indo-International web series with the idea of having exchange of knowledge with our London counterparts. And I am so happy that today is our 8th webinar and the topic is the theme is early pregnancy loss. In this, we are having 2 talks. One is evidence-based management of miscarriage and one is on a pregnancy of unknown location, which will be followed by a case-based panel discussion. And I thank Dr. Jyotsna Pundir for taking responsibility of doing coordination, rather full coordination at the end of RILG part. And thank you so much, Jyotsna, for giving us 2 vibrant, dynamic, very knowledgeable international faculties, Dr. Deepti Chima and Dr. Abha Sinha. Welcome you both on this platform. And I would like to hand over to Dr. Jyotsna for her opening remarks on this webinar.
Hi, good evening, everybody in India, and it's still good morning in the UK. RCOG India Liaison Group is grateful to be able to do these lectures and liaise with our Indian counterparts and exchange our knowledge and basically to improve the women's health at the end of the day. Today, I am really privileged to introduce 2 of my colleagues, Dr. Abha Sinha and Dr. Deepti Chima, who have very, very kindly agreed to put this program together. Without adding on any further, because we will go through their details as they give their talk, I would like to hand it over back to the chairperson for the first session. Back to you, Lakshmi.
So without wasting much time, we will start with our scientific deliberations. So Jyoti, please introduce the first 2 chairpersons so that they can take over. Yeah.
Thank you so much. Thank you, Dr. Jyotsna ma'am, Dr. Lakshmi ma'am, Dr. Deepti and Dr. Abha. And I welcome here for the scientific session first talk by Dr. Abha. We have the chairpersons. Can we have the CV, short CV, Dr. Vishal? Can we have CV of Dr. Vijay Lakshmi?
Yeah.
Yeah. So welcome Dr. Vijay Lakshmi, who's a senior consultant at Sundaram Medical Foundation, Chennai, who has been a past president of OGSSI and also a past Chennai's chapter secretary of IMS. So to cut short the CV, I would not be reading it out full, and I hope we all have gone through it very rapidly. So welcome Dr. Vijay Lakshmi for this wonderful and very prestigious session. And then we have the second chairperson. We have, next please. We have Professor Dr. Sampath Kumari ma'am. Ma'am, welcome to this platform. We feel honored that you are here today, and ma'am has been Chief and HOD of Muthu Kumaran Medical College and Research Institute, Chennai. She has been a FOGSI Vice President elect 2022 and founder secretary of the TNFOG, national correspondent editor and a chairperson of FOGSI Adolescent Committee in the past. So over to the chairpersons to introduce our first speaker. So ma'am has officially, we can just read out her CV, please. Next, yes. Over to the chairperson.
Thank you, Dr. Jyoti. First of all, I thank Dr. Lakshmi Madam for the wonderful opportunity. Now, without wasting the time, we will go to the chairperson's speaker, Dr. Abha Sinha. She is a senior consultant and a clinical director and in gynecology, oncology and breast surgery and Sandwell and West Birmingham IMS Trust. Back to Dr. Abha Sinha. She will be talking on the evidence-based management in the early pregnancy. Dr. Abha, stage is yours.
Good morning, good afternoon, everyone. And first of all, I would like to thank this RCOG India Liaison Group and the Indo-UK webinar for inviting us to do this talk. And thanks, Jyotsna, for introducing us to this panel. And Dr. Lakshmi has been so helpful. We have been always, texting her, emailing her that what's happening. It was a bit daunting, but now we are here on the screen and all the technology is working. So that's good. So shall I just start with the talk? Early pregnancy problems. I mean, I have studied and graduated in India and done my post-graduation before coming to the UK. It's a completely different ball game. We have early pregnancy and emergency gynecology units in most hospitals in UK, which is fully functional. And it's really the women are cared for. When I used to work in India, I think this there was actually population is so much. I have graduated from IMS BHU, and it was we never paid so much emphasis on this because the whole emphasis was on labor ward, the intrapartum care, and the not even so much on the postpartum care. So I found that this topic will be really helpful for my colleagues in India to practice and follow the guidelines. And it is very simple. We have got our guidelines in our unit or in Deepti's unit. We both work in Birmingham in big hospitals, serving like low 10,000 or more than 10,000 deliveries in each trust, and serving a lot of ethnic minority populations. So you will be very surprised to hear that maybe up to 40 to 50% of our patients or clients are from Asian background, be it India, be it Bangladesh, or be it Pakistan. So it feels home away from home. And I will start my presentation. We follow this is based on the RCOG and the NICE guidance. And this is what we follow in our trust. So it makes life very simple for us to manage the patient in an evidence-based manner. It makes life very simple for my trainees who are learning the right things. And then we can always justify our management, and it protects us against any medical legal issues as well. So that's why we have very strict guidelines, and my talks are based, as I already said, the references. So shall I just start sharing? I think it's slideshow. Yeah.
Yeah, perfect.
This was just an introductory slide about pregnancy of unknown location. So I thought I'll start with the basics, then talk a bit about research, which is not in clinical practice on a daily basis, and then conclude by finalizing and summarizing the talk. So the definition first. So what is a pregnancy of unknown location? It is when you have a positive pregnancy test and when no pregnancy has been visualized using the transvaginal scanning. And you'll be surprised to see that up to 18 to 31% of early pregnancy scans could be PUL to start with. In units where they have very specialized scanning equipment and highly trained professionals, the incidence can be as low as 8 to 10%. So out of these, 16% turn out to be viable intrauterine pregnancies, thankfully, and 4% are ectopics. So the diagnosis of ectopic pregnancy is, as we all know, is primarily achieved using transvaginal scanning, which is highly sensitive, 87 to 99%, and the specificity is 94 to nearly 100%. So if you can, there's no adnexal mass, then we call it a PUL. So 5 to 42% of women seen for ultrasound assessment with a positive pregnancy test have pregnancy of unknown location. So in pregnancy of unknown location, how are we going to now manage? So we measure the bloods, which is the serum human chorionic gonadotrophin, or HCG in simpler day-to-day language, and progesterone to predict what's going to happen next. So as we already said that 6 to 20% on an average of 16% of PULs can be subsequently diagnosed with ectopic. Non-tubal ectopics are relatively uncommon, very difficult to diagnose, and result in disproportionate morbidity and mortality, as we are all aware of. So the baseline, or the main way we can assess, is the full clinical assessment of the case. Then we do the HCG level, the serum progesterone, and then the transvaginal scan. Just a bit about the discriminatory zone, which I'm sure everybody is aware and using it in their day-to-day practice. This is the concept of combining ultrasound with serum HCG, and it refers to a defined level of HCG above which the gestational sac of an intrauterine pregnancy should be visible on scan with a sensitivity nearly 100%. The current recommended value ranges from 1,000 to 2,400, but usually most units take it as 1,500 international units. So there are some pitfalls. In multiple pregnancies, the HCG levels should be interpreted with caution, as they are a little higher, requiring an extra 2 to 3 days for the sacs to become visible. And a possibility of heterotypic pregnancy should also be considered. So the discriminatory zone predicts ectopic with a positive predictive value of nearly 18%, and transvaginal scan should be performed very carefully. How do we diagnose an ectopic? The main indicators are an extrauterine sac with signs of complex mass or echogenic fluid in the pelvis, rather than on a scan that fails to demonstrate an intrauterine pregnancy. So if you have an extrauterine sac with fetal heart or an adnexal mass or a lot of free fluid, the positive predictive value is quite high. So this value of discriminatory zone, as I said, units are taking from 1,000 to 2,400. That's all sort of, quite dependent on the quality of the scan equipment, the operator experience, and also the HCG assay techniques in use. Just a small picture. I'm sure we have all seen this before. The arrows are pointing towards the ectopic, and this is the decidual cast in the uterus. I thought this was an interesting one, abdominal pregnancy, and this is the uterus, bladder lying outside. So the rise and fall of HCG has to be interpreted with great caution, and this is what we normally use in our clinical practice to help us make the diagnosis and manage the case. So the usual figures quoted is that the minimal increase of HCG for an intrauterine pregnancy should be 66% in 48 hours. What we call the doubling is actually a 66% increase. This has a positive predictive value, nearly 96%. 13 to 20% of ectopics can have a similar rise, so we have to be very careful. So, sorry. The doubling of HCG is often expected in 48 hours. This varies with gestation. As the pregnancy advances, the doubling time lengthens. So again, we have to be very cautious in advanced pregnancy. The intervention for an HCG rise of less than 66% over 2 days a practice supported by previous data would potentially result in the interruption of a viable pregnancy. So we need to redefine the values in an effort to reduce unnecessary intervention. If the HCG falls at least by 15%, the most likely outcome is failing PUL. When the rise or fall is suboptimal, the most likely outcome is ectopic pregnancy. So talking about progesterone, I mean, the current guidance does not, the first level is important, but we do not do it in a serial level. So the progesterone values less than 20, more often associated with non-viable pregnancies, but a very, very small fraction of viable pregnancies may have less than 20. Serum progesterone less than 20 predicts failing pregnancy with quite a high PPV. More than 60 are strongly associated with normal intrauterine pregnancies, but again, there is a small caveat and a small proportion of ectopic may have more than 60. So what are the current diagnostic challenges we all face, even working in the UK, which is access to expertise and equipment for high quality transvaginal scan, identifying PUL, which are low risk, finding better serum markers for ectopic pregnancy. This was from an RCOG document I read. I think it is just still in research. It's not used in day-to-day practice. And then we have to safely identify women who do not require intervention. That's our aim, to be trying to manage conservatively and not miss the high-risk cases, to minimize surgery. So the new serum markers, as I said, they are all only in research. They talk about the CA125, can distinguish PUL from intrauterine, the vascular endothelial growth factors, the TNF, PAP-A, SP1. I won't go into much details because these are not used in our current practice in the UK. I'm sure, I don't know about India, but we are here to exchange our knowledge and hopefully we'll learn something new. The clinical possibilities. So if you have a positive pregnancy test with an empty uterus, what could be the possibilities? So either it's a normal intrauterine gestation, too early to be seen, ectopic, too early to be detected on the scan, or a viable pregnancy missed by the scan, ectopic missed by the scan, or a failed intrauterine or ectopic gestation. So the outcomes on PUL, as I said, a few percentage will be ectopics, the rest will resolve with conservative management. A few of them we have to treat by using medical management. The remainder will be intrauterine pregnancy, which is the good news. So studies have, in my previous slide, that 6 to 20% will develop into ectopic. And our main aim should have the strategies to predict ectopic in PUL population using the various biomarkers and repeating the scan, the internal, the transvaginal, in order to avoid delaying the diagnosis. So the way we manage here, that all the such cases are always discussed with the senior gynecologist, by which I mean the consultant. We have dedicated gynecology consultants on call in all our hospitals in the UK. Obviously, management is, the initial thing is good history taking, including the presence of risk factors. For ectopic, the baseline observations, do initial set of bloods, which is the full blood count or the complete blood pick count, a group and save serum in case you are suspecting the patient to have intraperitoneal bleed. Then we do the serum HCG. Very simply, if it's more than 1500, laparoscopy should be performed. Less than 1500, then only we check the progesterone level. So if the progesterone is more than 60, viable intrauterine pregnancy is likely, and then we can repeat the HCG and then repeat the scan once the HCG is above 1500. If it's less than 20, failing pregnancy is more than likely, and you can, if the patient is well and asymptomatic, repeat HCG in 7 days, and you can discharge if the level is less than 20 or a fall is more than 50%. The group in between, more than 20 but less than 60, we repeat the HCG in 48 hours. If the rise is more than 66%, likely intrauterine, and repeat scan once the HCG level is above 1500. If there is a fall of more than 50%, it's a spontaneous resolution of pregnancy, likely, no further follow-up. If there is a static level or rising less than 66, then we do one more repeat. So management will always be expectant medical and surgical. So expectant management can be done. It is safe and it reduces the need for unnecessary surgical intervention. If we have made a careful assessment of the case and taken into account all the HCG and progesterone levels, we can be sure that there will be no serious adverse outcomes. The patient are counseled. They are giving all the safety netting advice when they are on expectant management. They may need multiple visits to an early pregnancy unit, which are dedicated units. We have clinical nurse specialists and doctors who are working there, so who follow the guidelines. And then eventually we will reach to a diagnosis. And sometimes the visits can be up to the range of 2 to 6 visits before we can discharge this patient. But the median number is 3. We try to minimize as best as we can, but not all pregnancies and HCGs follow a standard path. So more visits may be required. I mean, people studied about a single visit strategy to reduce the number, and it was shown to be quite unsafe, as 67% of women with ectopic were discharged without adequate follow-up. So single visit strategy was then, we just gave up and decided that we have to have more than one visits. Up to 30% of case may require intervention because of either worsening clinical condition or the HCG remaining static. The intervention normally used, active intervention, medical or surgical. So it has to fit the criteria. So if there are symptoms of ectopic happen or ectopic is diagnosed, HCG is more than 1500 or it starts to plateau, we have to do the active intervention. Patients with PUL should be given the benefit of doubt of possible ongoing intrauterine pregnancy. And in our unit, we do not give methotrexate unless we satisfy the following 4 criteria. The first one is the selection criteria for methotrexate, which is the one which we use for ectopics. Then we at least do 2 serum HCG levels. We will never give with 1 level. And if the 2 levels show a static or a suboptimal rise, then only the methotrexate will be given. The progesterone has to be less than 20. And we do another transvaginal scan, which we fondly call as a methotrexate scan, performed on the day of the injection by a different sonographer for a second opinion, and it continues to show no intrauterine pregnancy. So methotrexate with an XL mass is easy. We follow the RCOG guidance, look at the HCG level and the size of the mass, and it can be given. But in PUL, we are very strict, and we follow this pathway before the methotrexate is administered. Always repeat the scan, have 2 levels of HCG, make sure the progesterone is less than 20. A NICE guidelines state that for women with PUL, when using serial serum HCG, do not use the progesterone as an adjunct. But in our unit, it's used as an extra safety measure alongside declining a static HCG and 2 scans. Because we had a case where there was an issue, and from then we sort of modified our guidelines. And if we have any concerns or uncertainty, laparoscopy is the best option because it will not disturb an ongoing intrauterine pregnancy. So the medical management, day 1, do the HCG level, fulfill all the criteria, and obviously you will do the full bit count, use an EASE liver function test, give the HCG, the dose is 50 milligram per meter square. Day 4, the HCG is repeated, and then day 7, repeat. Second dose can be given if the drop is less than 15% on days 4 to 7. But if there is a rise, then we have to repeat the HCG. There will be an initial rise on day 4, and that is expected. So if the patient is well, there's no need to panic. So as I said, that initial rise, many women may become symptomatic and they come back that they are having pain. So we have to carefully assess them. The risk of rupture is there in about 7%. The mean time to resolution is 35 days. Surgical management, laparoscopy is the gold standard if the woman is symptomatic or if you visualize an ectopic eventually. Sometimes early ongoing and self-limiting ectopics are too small, and you can have a false negative laparoscopy even at the rate of 3 to 4%. There can be a small false positive in laparoscopy with the retrograde uterine bleeding. So we always explain the need for further follow-up and give appropriate information to patient. And this is the pathway we follow in our unit. I'm sorry, I think it is a bit small. Can you all see the algorithm? So the PUL at more than 6 weeks, we do the HCG. If more than 1500, we go down the route of laparoscopy or methotrexate after satisfying all the criteria for methotrexate. Less than 1500, repeat in 48 hours. If there's a static or suboptimal rise, go down the laparoscopy or methotrexate route. If the level decreases, you can follow up till negative urine pregnancy test. If the level increases by more than 63 to 66%, it's very likely intrauterine. We'll repeat the scan once the level is more than 1500. If still PUL, please follow the laparoscopy or methotrexate path. It's the same thing. This is from NICE guidance, and it's exactly the thing which we have adopted in our unit. So just the prognosis, as I said, up to 70% may resolve. Ectopic may be diagnosed in 14 to 28%. Early intrauterine pregnancy, too small to visualize, contribute to up 30 to 35% of PUL, and 75% of them will be viable pregnancies. Persisting PUL and HCG failing to decline, we have to be careful about gestational trophoblastic disease and then make appropriate management. Serum progesterone less than 20 is in most cases predicts failing pregnancy with a very high positive predictive value. However, we should always be careful and take active intervention, and uterine evacuation should not be undertaken just based on low initial progesterone. Viable pregnancies can also happen in about 0.3% cases. It's very small, but can happen. So we have to put the whole picture together. I think that's the bottom line here. So this is the final slide, just a bit more pictorial. And I think that's the end of my talk. Thank you very much, all of you, for patient listening.
Thank you. Thank you, Abha. That was wonderful. And in fact, initially, Lakshmi for giving me this opportunity. It's a great honor. And Abha, yeah, you really elucidated and completely clarified everything that we do for the pregnancy. And we do know that though a small number, about 8 to 10%, but the entire diagnosis and management centers around the ultrasound, a very good precision ultrasound, and of course the beta HCG levels. We also don't do other tumor markers, to my knowledge, in India as well. And of course, serum progesterone, many of those cases as well. For you have tabulated very well, and you did tell that we have to be diagnosing and also managing pregnancy or location. Many of them could progress the topic, diagnosis of ectopic or the diagnosis of failing pregnancy or even early viable. Thank you very much, Abha. That was wonderful and nice to hear.
Dr. Abha, only one case. In our hospital, we had one case and we gave that MTX, and after that also the beta HCG was in rising level. Then we went for laparoscopy and it was found to be an ovarian pregnancy.
Yeah, very interesting. Yeah, I have got a case presentation. I made one and I haven't made one, but I will happily discuss. HCG levels can be raised in various things, which we always miss. And whenever a woman is there with the period here and there, and HCG level is recorded or positive pregnancy test, everybody starts thinking of an early pregnancy problem. So one of my cases was very unique, that it was something entirely different. And another case I will just share verbally. I haven't made the presentation, which completely shocked us all. So I will leave it to the later discussions. And
thank you. Thank you.
I left India 20 years ago. That we are working on similar, the thought process is similar, and we are all aiming to give the women the best care and look after the women's health.
But only thing we have to follow. That is very, very essential.
That is the thing. And here, we follow the guidelines. And if you deviate from your local protocol, you have to give justification if something goes wrong. And that is done morally by all of us, isn't it, Deepti? So we just follow the guidelines. And everyone will follow.
Thank you, Doctor.
Can I put a point here? Dr.
Yes.
I am Dr. Kishore Razurkar from India. And I just want to point you have already stressed, but I just want to stress that PUL is it is not a diagnosis of
Yes.
ectopic. It is a unknown location. Therefore,
Yes.
you should not start methotrexate till it comes out to be ectopic. Just if you have made a diagnosis of PUL but you are not getting SAC anywhere, neither intrauterine or extrauterine, beta acid is higher. Sometimes what the residents do, that they will give a course of or a shot of methotrexate. Why I'm saying this, as you have already told, that it can be many times it can be an intrauterine pregnancy which will be detected later on. Number two, about 15% patients of normal pregnancy will not be having this 66% rate.
Yes, that's what I said.
About 15%. Therefore, I always say that if you make it follow this patient, you have to follow according clinically. If everything is fine, you have to follow clinically. We don't do the progesterone, but we do the beta HCG and the clinical evaluation. And also the examination, clinical examination is also important. Just don't do like just coming the beta HCG and like that. So I think this point for us is important. And once you make a diagnosis of ectopic pregnancy, then you give.
Yes. We have to be very careful because there was a problem once in our hospital, the ultrasound probe, the microcrystal in the probe, the part of it was broken. So that's the SAC in the area.
Only photo I think of total EC.
We are not able to hear you clearly, Dr. Abha.
Oh, can you not hear me?
Now it's okay. Yeah.
Okay, yeah. So yeah, I'm happy we can carry on with the rest of the meeting.
Yeah.
Sure.
So it was a very, very informative talk, Dr. Abha, and I'm sure we can continue with our discussions after the panel discussion is over. So now it's my privilege to introduce the chairpersons for the second session. Vishal, please share your screen. Yeah. It's a privilege and pleasure to introduce Professor Gokulda, who is my elder brother. He is professor and head OBGYN department, Guwahati Medical College. He was Vice President Foxy way back in 2014. And he is a dedicated teacher, academician with lots and lots of publications. And he gave us a very wonderful AICOG in 2010, where he was organizing chairperson. Welcome, Gokulda. And our next chairperson is our own convener for Indo-International Web Series, the multi-talented, multifaceted, dynamic Dr. Jyoti Malik. She is medical superintendent of JJ Institute of Medical Sciences, Bahadurgarh. So I invite both the chairpersons to take over.
Thank you so much, ma'am. Thank you. I think it is an honor to introduce our next speaker. And then I would request Gokulda sir to sum up the session, he being so much experienced. So our speaker, Ms. Deepti Chima, is a consultant obstetrician and gynecologist, lead in Gynec Governance, University Hospital, Birmingham. Over to Dr. Ms. Deepti Chima, please. And she would be talking on the management, evidence-based management of miscarriage.
Hi, everybody. Thank you for this. Can I just say that how delighted I am, despite a very good weather here, to be sitting here with Abha and exchanging knowledge. The topic that I'm going to cover in next few minutes is about evidence-based management of miscarriage. I appreciate it is a very common presentation, and I'm sure all of us are up to speed with the latest evidence and how to manage these patients. But I hope there'll be one or two points that you might be able to take from this presentation. How miscarriage is defined depends on that country would consider the gestational viability. So in UK, we follow the NICE guidelines, and we have any pregnancy loss, spontaneously occurring loss, less than 24 weeks would be a miscarriage. And for obvious reasons, for WHO, the gestational viability is higher, and that becomes anybody with less than 28 weeks. Unfortunately, miscarriage is common. In clinically recognized pregnancies, it ranges in the range of 1 to 5 pregnancies. And in biochemical pregnancies, the rate tends to be higher of about 30%. One of the common classifications is based on gestation, where a pregnancy loss less than 13 weeks is called as early miscarriage, and beyond would be late miscarriage. And commonly, we classify miscarriage based on patient's history and examination findings, where it could be a threatened miscarriage or inevitable when cervix is opened. And depending on whether the products are expelled fully or incompletely, it becomes an incomplete or a complete miscarriage. Sometimes the diagnosis will be based on scan, where you would do a scan where patient came with bleeding or pain in pregnancy, or just for a reassurance, and we find that pregnancy wasn't continuing. In that case, if a fetal pole was seen and where you would expect to see a fetal heartbeat and it was absent, it becomes a miscarriage. And when only the sac is developed with no fetal pole, it is an embryonic pregnancy. Previously, it used to be called as blighted ovum, but we've moved away from calling this as that, and now the consistently used term would be an embryonic pregnancy. For recurrent miscarriage, it is key is that they are consecutive miscarriages. It used to be 3 or more, but now any consecutive miscarriages of 2 or more will be called as recurrent miscarriages. Ultrasound scan is often the first modality we use when a woman in pregnancy is stable and comes with bleeding. And the idea of a scan would be when we have ascertained that the pregnancy is inside the uterus. So we know for sure that it is an intrauterine pregnancy. Then the first thing will be to check the fetal heartbeat. If fetal heartbeat is present, then we can reassure the woman that it's a viable pregnancy. If fetal heartbeat is not seen, then important thing is to determine whether would we expect to see a fetal heartbeat, and that should be dependent on the fetal pole. So if you see a fetal pole, measure the crown rump length, which will be top of the crown to the rump, and if it is 7 millimeters or more, then we should expect to see a fetal heartbeat. And if that is the case, then you can say that it's a miscarriage. But if it is smaller than that, then this is a pregnancy of uncertain viability. And similarly, if fetal pole is not developed, then we go down to look for gestation sac. Is it there, and how big is it? At about 25 millimeters of main sac diameter, you should start to see a fetal pole and developing. So if it is bigger than that, then that would be an embryonic pregnancy. Very, very important things to consider when we have a scan is that intrauterine pregnancy of uncertain viability, which we usually just say IPUV, and this is where the CRL is less than 7 millimeter, or MSD of a sac is less than 25 millimeters. In those situations, we will not call it a miscarriage. We will rescan the patient, and hopefully minimum interval would be 7 days for a transvaginal scan. And if for any reason patient is refusing a transvaginal scan, then transabdominal should be at least 15 days apart to appreciate any growth in the baby. And then in the subsequent scan, if you've seen growth of the baby and whether it's hit the 7 millimeter or 25 millimeter mark, you can classify accordingly. But if it hasn't, then you'll give more time to establish. So we'll not be in a rush just based on the scan to disqualify a pregnancy. We will give it ample time, ample opportunities, so that we are absolutely sure to give that diagnosis to the woman. Well, other thing where sometimes people could get caught out is they do a scan first time in the pregnancy, and woman gives a history of losing some products, and we do a scan and find completely empty uterine cavity. So we cannot call it a complete miscarriage because it might be a PUL, which Abha has covered in the previous talk. until unless there was a previous scan and we've seen a fetal pole or evidence of intrauterine pregnancy, and on this scan we can't find anything, that will be the only time when you can be really sure to say that this is a complete miscarriage. Otherwise, we would follow them up with either HCG or a repeat scan to make sure that we are not missing an ectopic pregnancy. Threatened miscarriage. There is this one keeps on changing. I think this is the most contested thing where a woman comes with the bleeding and you do a scan and either it's uncertain viability or you've established a fetal heart. And then obviously as clinicians, we feel we have to give this pregnancy maximum chance. And women also wants to know what more could you do so that, you know, it ends in a live birth at the end of this. So in UK, we, as Abha has mentioned, that we do tend to follow a consistent advice so that we all are singing from the same hymn sheet and practice from what is the most up-to-date evidence. Often, if a new very good quality research comes out, there is obviously a lag between Royal College and NICE to reflect that. But often, if it's a very significant move, then they will update the guideline as an interim measure, just revise that aspect of it and let us know what we should be doing. So previously we would just tell a woman, okay, we've seen a fetal heartbeat. There is a 95% chance your pregnancy is gonna go well. Just take it easy. She doesn't need to do bed rest and things like that. She can carry on with day-to-day activity. But however, I mean, she should take things easy. Nowadays, with the trials of effect of micronized progesterone, we've changed our advice, where if a woman who has had no previous miscarriage and just has a bleeding, we will reassure, send her home. And then often these women will want to know what will happen, should they come back if they keep bleeding and all of that. So we say, okay, wait for 14 days until unless bleeding becomes heavy, then obviously she will present to emergency. But if it is a light bleeding, then at 14 days, if it is persisting, then we will rescan. If a woman has had a previous miscarriage, then we will commence them on micronized progesterone. And the dose we would suggest is 400 milligrams BD. And they continue this until about 17 weeks of pregnancy. The role of progesterone is that it has shown improvement in live birth rate of women who've had bleeding and have had previous miscarriage. The trials have only been for micronized progesterone. So that is what we do not extrapolate to other progesterones. So recommendation will be only to use micronized progesterone. And the dose is also same 400 milligrams twice a day. When it is not shown to give any benefit is when patient has no previous miscarriage but is bleeding, or has not had or has had previous miscarriages but is not bleeding now. So in those patients, it's unlikely to give benefit. That is what the current evidence suggests. Once we've diagnosed a miscarriage, then the options will include expectant management, medical management, or surgical management. Expectant management is often used first line, where depending on whether the woman is suitable for it, for example, women who hasn't had a previous traumatic experience understand natural process of miscarriage will involve certain degree of pain, certain degree of bleeding, risk of heavier bleeding. And so if psychologically and things woman is prepared, accepts that, and she has got help available where somebody can bring her to hospital if emergency was to happen, and she's not got coagulation disorders or high risk of bleeding problems, those women will be appropriate to follow the expectant management. And what we can reassure to them that most of them, now when I say most of them, anything above 50% would be most of them. So around 58 to 60% of women will, if they follow this advice, expectant management will end the miscarriage for them. We give them pain relief, we give them contact details because we have 24/7 number they can contact and come in. And we review them at 14 days. If nothing has happened in 14 days, then we reassess the situation, rediscuss the options, and then follow it through. At 14 days, if woman still chooses to continue, then we would continue. And then if patient does give a history of passing the products or a heavier bleed, then we'll suggest do a pregnancy test in 3 weeks. And if it is positive, then get in touch. And review, as I mentioned, that it will be to continue or follow with a different one. With regards to medical management, at the moment, our advice is to give misoprostol. Now, the evidence is that for an incomplete miscarriage, 600 microgram dose is effective. And for missed miscarriage, 800 microgram single dose is effective. However, to save the confusion between what type of miscarriage, most trusts in hospital would follow a standard 800 microgram dose, which we recommend vaginally, but women can decide to take it orally. And the side effects, we do explain to them that they are likely to experience pain and GI side effects, and expect to have the process started in 24 hours. For our patients who are not at high risk of bleeding, we do give this as outpatient option, where either they go home and do it themselves, and we give them a choice of pain reliefs. They are often over-the-counter tablets, which they'll just have at home anyways. And then do advise them to do a pregnancy test in about 3 weeks. If in 24 to 48 hours nothing has happened, then we give them a ring and then bring them back to see whether we should give a repeat dose or just give it more time. The longer time you give, the more likely it will become success. But then often if 48 hours nothing has happened, then we will review and give the option. At the moment, we do not give mifepristone. Traditionally, it was always given, but then when the latest NICE came out, it showed no difference. So therefore, that was taken off. But it might be doing a comeback because recent trials have again shown, and which I will cover in the next slide. Misoprostol or Jamipros, both are prostaglandin E1 analogs, and they have similar efficacy. However, misoprostol, because it is cheaper, it is stable at room temperature, it is what we use. And it just makes sense because they both are equally effective, and one is more convenient to use and cheaper, and also outpatient. She can take it in her handbag and use it at home. So it seems to be more favorable option. Oral or vaginal are the first modes choices of route to give because they have slower absorption, lower peak levels, and slower clearance. So it is extended release and tends to work. Sublingual absorbs very quickly, has high peak level and higher GI side effects. Good thing about prostaglandin is they don't have any drug interaction, so we don't have to look for whether it will interact with another drug or not. Now, prostaglandin are used for, as we know, for GI ulcers and things, and that is what it is licensed for. It is not licensed in UK for a use of miscarriage, but obviously we do use a lot of unlicensed medications when we have clear evidence that they are beneficial, so it is recommended and widely used. The common side effects are GI side effects, dizziness, or fever and chills. If they take it buccal or sublingual, then sometimes patient will describe unpleasant taste or local numbness in the mouth. Medical management has higher success rate than expectant management. For incomplete, it is sort of 99%, which one would think is even better than surgical management, to be fair, which we quote as 95%. And it ranges for a missed miscarriage, it is between 60 to 83%. So overall, it is considered to be a good option for the woman. Although this is not an early pregnancy problem, but for women beyond 13 to 28 weeks, I've just covered in one slide that we would give mifepristone oral, and then we admit 36 to 48 hours so that mifepristone has activated the receptors, and then prostaglandins can go in. And then we classify women as low or high risk, and for low risk, it will be 400 microgram 3-hourly dose, maximum 5 doses, and for low risk it will be half the dose and twice the interval, so 200 at 6 hourly, and the maximum dose is 1600. So I would cover mifepristone because I just said it is used, and there is a good chance that it might be something which will come back into action. It is a synthetic steroid. It antagonizes the progesterone receptor, so that is how it will work and it increases the sensitivity of myometrium, so that when we give prostaglandins 36-48 hours later, they are working well. Then our next management option is surgical management, which sometimes is a first-line option for women who are at risk of excessive bleeding, who have infection, or when you're suspecting a molar pregnancy. Sometimes women might choose it for the sake of convenience or previous traumatic disorder, or somebody who might be approaching 39, 40 years of age and has to plan her next pregnancy pretty soon rather than keep waiting with the other options. We do also have the surgical management under local anesthetic, which I would love to hear from you whether this is something we do in India. So this is like a syringe which generates a manual vacuum. You just push the plunger, it will create a vacuum sufficient enough to complete the procedure. So this is done under local anesthetic. For all rhesus negative women, we would give NTD within 72 hours, except for pregnancies which have very light bleeding and less than 12 weeks. So anybody over 12 weeks, and then molar pregnancy, ectopic, or those where we will do active management of a miscarriage. We could facilitate all of these options because we have a very good service setup of early pregnancy assessment units, because these are often 7 days a week open and women can self-refer to them. So it might not be an option where this would be difficult for women to achieve to come in emergency. And these EPAU services are very well run. They are multidisciplinary, where they've got trained sonographers and blood test facilities to keep and chase the results and follow the women. So they're pretty much self-sufficient run. They follow their own protocols and things. And everybody, apart from the clinical thing, they have had a good training in communication about and counseling about, when there are bad news to women. Recurrent miscarriage, I would just cover in 1 or 2 slides, which is, as I said, it was 2 or more consecutive miscarriages when they are early. However, if a single pregnancy is lost beyond 12 weeks, then we would investigate that as well. And like everything, it will be history determined, BMI, because a lot of women might need BMI counseling to optimize their future pregnancy. Then at the we do blood tests to check for diabetes, thyroid function, full blood count, vitamin D, calcium, and thrombophilia screen. We do consider karyotyping not as a first line, but when you suspect somebody is having recurrent miscarriages, and if the fetal or the pregnancy tissue was examined and it has shown balanced translocation, then both partners' karyotyping is checked to assess this. If the results then come back abnormal, for example, if their HbA1c came back as high, then we will organize a GTT. And if they are diabetic, then they'll be tailored to optimize their diabetic control, and that will increase the success of pregnancy. If thyroid function tests were abnormal, then we'll refer them to endocrinologists to optimize that. And if somebody has a positive antiphospholipids test, then we will repeat it in 12 weeks. And if it is negative on the second test, then no further action will be needed. But if it is positive, then there is clear evidence that low molecular weight heparin and aspirin will improve their future pregnancy. So whenever they have a positive pregnancy test in future, they will have the option to start this, and GP will be informed so that there's no delay in them getting the prescription. And then if these women then present, then if we have ability, we would offer them fortnightly scans, especially the antiphospholipid syndrome women, mainly for reassurance. And then if despite recurrent miscarriage, unfortunately, the next pregnancy then miscarries, then it is sent for cytogenetics. And what is important is often this mistake happens where people would send it in formalin and the lab would reject. So this sample has to be sent in a normal saline. The important points are that importantly, it is a transvaginal scan which should be determining about how we classify the pregnancy. And we would not classify pregnancy of uncertain viability as a miscarriage. We would give it time to see. And the 2 important numbers to remember is 7 millimeters and 25 millimeters. And for a transvaginal scan, we would scan in 7 days minimum. That is by no means the only option. You could stretch it to 10 days or so. And then for transabdominal, the minimum interval would be 14 days. If pregnancy was more than 7 millimeters CRL and no fetal heart seen, then we have a safety measure where second person will scan either on the same day or to confirm, or we'll bring that patient if that option wasn't there for another scan, so that we've sounded that through to make sure the chance of ongoing pregnancy was 0. And an important thing not to confuse a complete miscarriage and a pregnancy of unknown location, and the misoprostol regime. And watch the space. Mifepristone, as the most recent evidence does suggest that it is actually effective. And we will be waiting and seeing whether that comes back into practice. And one of the very forthcoming things is TOMI Center, which is a very large charity-based research center in UK. Lot of research from early pregnancy and miscarriages happens over there, and they update, and they have been instrumental in a lot of recent changes in practice. So from time to time, it will be worth visiting TOMI's website to see what is new, what is ongoing, and how will it affect our practice. Thank you very much.
Yeah, thank you so much. Thank you, Dr. Cheema, for that wonderful and very crisp, very, very to the point talk. You've covered everything very nicely. There are 1 or 2 questions also in the chat box, if we can take them. I think one doctor has asked, one doctor, I think Kishore only has asked if you give NSAIDs also along with misoprostol or not.
So yes, we would give them ibuprofen, but we usually start with paracetamol and things, and often patient will have their own, but we will not, ibuprofen is fine with misoprostol.
Okay. And do you feel some of the patients come with very heavy bleeding and they need to go in for a surgical evacuation? What is the percentage and how do you counsel such patients?
So if a patient is coming very, we probably see that every 2 to 3 weeks there will be a patient. Some of them we already know because we've scanned them and failed pregnancy, and some of them would just come out of the blue. But then if somebody is bleeding very heavy, there is surgical evacuation under GA would be the appropriate option. In those patients, we wouldn't be waiting, but we'll follow, the emergency protocol where we have emergency call goes out, the blood bank is informed, bloods are cross-matched, we have O negative blood available. We will resuscitate the patient and transfer to theater for evacuation.
Right. Over to Dr. Gokul Das, sir, for his expert comments.
Thank you. She has said so nicely, all practically. She has spoken, almost covered all the aspects of the management of the miscarriage. So I don't have to add more because things should keep on changing. And problem in India will be to again manage the patient who will be having excessive bleeding. That becomes like in UK they have everything ready, but here again you have to arrange everything. That is the biggest problem that we face.
Yeah, so, and you probably have more anemia as well.
Yes, that's true. There will be some differences because of the situations and the infrastructure problems. Otherwise, it's a very nice talk, and I really enjoyed the talk. And yes, misoprostol has really taken over in the management of the miscarriages. That is the best thing to happen.
Is misoprostol readily available in the community remote centers? For example, for postpartum hemorrhages and things like that?
More than readily. Because even our chemists give that. I mean, they are not eligible to give that, but half of our medical termination is being done by the pharmaceutical people here, which is though not allowed, not legally allowed, but half of our patients come self-medicated, taking the medications and within complete miscarriages. So it is very readily available, not an issue of availability though here. Yeah. So thank you for that wonderful, wonderful session, Dr. Deepti. And again, now we have a very, very interesting session on the panel. And we have expert panelists that Dr. Lakshmi has brought from all over India that she has chosen very nicely. And for the same panel discussion, we have moderator Dr. Deepti again and Dr. Lakshmi from India. So Dr. Deepti would be sharing her cases, and then we would be taking all our 5 Indian panelists' views, and then expert Dr. Alka, Dr. Abha Sinha's expert comments as well. So over to Lakshmi ma'am to start the panel.
Yeah, Vishal, can I have the slide of panelists, please? I would like to introduce them quickly. Dr. Chima will be moderating, and she has already been introduced. And we have galaxy of experts. First, Dr. Parikshit Tang. He is consultant Ashwini Maternity and Surgical Hospital, and he has logged in from Mumbai. Welcome, Parikshit. Next, Dr. Shamal Sheth. He is consulting practicing gynecologist, and he has logged in from Kolkata. Welcome, Dr. Shamal. Next, Dr. Rujuta is from my own Orange City, Nagpur, and currently she is Associate Professor, OBGY Department, Government Medical College, Nagpur. Welcome, Rujuta.
Thank you, ma'am.
Dr. Kishore Rajurkar, he is Senior Consultant Gynecologist and Perinatologist, and he has logged in from Delhi. Welcome, Dr. Kishore. And Dr. Parag Binimale, he is Senior Consultant OBGY, and he has logged in from Pune. So welcome, Parag, and I hand over floor to Deepti. Deepti, please start sharing your cases.
Thank you.
Parag has not logged in, I think. Parikshit, are you with me? Yeah.
Shall I start?
Yeah, please start.
This was a woman who was 28 years old. She has 2 children, and both were delivered by cesarean sections. And 1930, I said on the top, is the time she came to A&E, because it is important that we put in context what time this very stable lady just presented to emergency department, and her symptoms were abdominal pain and bleeding. So both of them not very significant, but enough to trouble her. And when she was examined, her abdomen was soft. She had mild tenderness suprapubically. There were no adnexal masses palpable, and cervix was closed. Pregnancy test was positive. And so with these very mild symptoms, the woman had presented was basically, she had visited country abroad. So she had come from Pakistan, bringing this report, which suggested that she might have a chronic ectopic pregnancy. So over there, it will cover in the next one. So whilst she was visiting her family over there, at that time she was pregnant, her HCG was more than 1,000. They did a scan over there, and they said she may have salpingitis or she has a ruptured ectopic pregnancy. They offered surgery, but women declined, and she came back to UK with these symptoms to seek further help. So what would your thoughts be if a woman comes with a suggestion of a chronic ectopic pregnancy from a scan somewhere else? I suppose we would like to do a scan ourselves in our department, or somebody we can trust to give us a little more information, because often you wouldn't know the quality of the scan that she would have brought. So we did a scan ourselves, and the scan report said it was anteverted uterus, endometrium measured 12 millimeters, and there was no ongoing pregnancy inside the uterus. And the right ovary was normal, but in left adnexa, she had about 13 centimeter mass, and which could be a hemorrhagic cyst or a hematoma from chronic ectopic pregnancy. The ovary wasn't seen separate to this. So, once we had the scan finding, a plan was to admit her and do her HCG levels, and patient is stable. It's a chronic ectopic pregnancy likely. So we see her in the morning when the consultant does a one round, and consider a surgical management. By then the HCG would be back. So now from what should have been a one-day thing, this became a long-standing. She was seen repeatedly every day. First day, her HCG came back 248. And the plan was, let's do an MRI scan in case this could be not ectopic pregnancy, this could be a tumor or something. And let's discuss in MDT discussion. So MDT, all hospitals have a multidisciplinary team discussion for oncology cases or suspicious oncology cases. And then these tend to happen weekly, and we'll get updates. So we could refer patients from general gynae clinics when we are worried, and so that MDT plan is made and it's consistent for all patients because it's shown to improve the outcome for cancer patients. Then, so day 2, she's seen again, her hemoglobin is dropped from 87 to 77. So plan was to give her iron and wait for MRI. Now MRI happened on day 5. So in between, she had another HCG, which was stable from 248. It had become 225. And MRI scan showed that it likely represents a hematoma from a chronic ectopic pregnancy. There was a one large lymph node, but it was not found to be significant. And then the patient kept waiting for MDT discussion. And then on 7th day from admission, she was getting fed up and her pain was getting worse. The plan was to go ahead with surgery. Same day was MDT, and MDT decided on the images as well that it did look concerning, and then to proceed. So the patient went on for the surgery, so started laparoscopically, but then it was all quite matted, everything joined together. Apart from uterus, you couldn't distinguish where the tube ovary was. And then she had a mini laparotomy, and she had hematosalpinx on the left side, and she had ectopic on the right side. And so this tube was removed and histology confirmed chronic ectopic pregnancy. That is the end of this slide.
Yeah, Dr. Shamal, your comments on case 1. Please unmute, Dr. Shamal.
I think the moment you could find that the hemoglobin level is going down, that was the moment you should take the decision of surgery, although beta ECG level was also going down. And in our setup, what we do, a patient having already 2 babies with this kind of findings, a big mass, it's a 11.7 centimeter. We are not going to get any further benefit when waiting by medical management or whatsoever. So that should have been the decision after proper counseling, and one should have gone for the surgery. I think we should not have waited for day 7. We could have gone for the surgery within 1 or 2 days. This is what we do in our setup.
Yeah.
Shweta, you are from Government Medical College.
Yeah, even I agree with Dr. Seth. Yeah, because we cannot afford to wait for 7 days in such cases, because there's a huge hematoma, 13 centimeter hematoma. It needs immediate evacuation. It needs immediate exploration. That is the thing. And yeah, and even in this cases, I think MRI was indicated. I have this question that it was really indicated, because on USG it was pretty clear that it's a hematoma and the history was suggestive of chronic ectopic. So even we would have gone for immediate exploration of this patient without giving her a conservative management. And I think a role of a HCG comes when we have a doubt of diagnosis, we have a doubtful diagnosis, or when we are not clear about our diagnosis, and when there is a small collection in the pouch of Douglas, which we are expecting to be cleared in a few days. So at that time we can, and when there is a doubt of a pregnancy which is still viable in the extrauterine pregnancy, which is still viable, in that case we can have a serial HCG measurements and we can have a role of conservative management. But in this case, surgical intervention was clearly indicated.
So
yeah.
I think
we will have the inputs, because we practice in a resource constraint setup, and we don't have very clear-cut guidelines as far as we in India are concerned. So we will just hear the inputs from all, and then you can give your expert comments. Yeah, Dr. Kishore.
What actually I also feel that there was a delay in, and with all the reports also of the chronic ectopic, and you have the patient who can examine, you must be having clinical findings also, and the HB was dropping. All this was, I think, MRI, if you wanted to do, it's fine. But I think intervention. Achha, ek aur thing I saw that you wrote down oral iron was for what? There was no need for giving any oral iron. I saw one slide. I think some oral iron. That was absurd. And therefore, I think, and theek hai, definitely you have a doubt of this thing. You must rule out the.
Sure, I think there is some network problem. Parikshit, are you with me? Parikshit, can you please unmute? Parikshit is busy. Yeah.
I think one comment. I think this case was managed in an academic institution, a teaching hospital.
Yeah,
so
they could
all
afford
these things
to
are
do
actually
so much
being done in the
follow-up.
teaching institution. These MRI, etc. Yes.
MRI, I mean, their patient, they don't have to pay from their pocket, and they are in the institution. Their patients are well aware, educated. They understand what they are going through. They come for follow-up. But in India, the things are totally different. Yeah, Dr. Kishore, in between you got muted. Yeah.
No, and therefore laparotomy, matlab laparoscopy की जरूरत नहीं है इसमें. Do a laparotomy because you are expecting adhesions, you are expecting so many things. So therefore, in chronic, because chronic ectopic actually is diagnosed many times without any symptoms. I was doing a lab sterilization of a patient, and I got a chronic ectopic. Lab sterilization can be. So therefore, I think chronic ectopic diagnosed, Pakistan should get, I mean, wherever she got it done, they should get the credit diagnosing it. And then I think management to, and one more thing about beta SCG. In chronic ectopic, beta SCG can be normal, urine pregnancies can be normal, serum beta SCG can be normal. So this thing also should be considered. But isme the positive tha. Therefore, that is more in favor that chronic ectopic is diagnosis. Thank you.
Yeah, Dr. Abha. Yeah, now you heard the Indian version, because I told you we have different scenario and we have our different constants. So your expert comments before we close down the case one. Yeah, Abha, please.
Can I just answer some of the questions, because the patient was from my hospital.
It is interaction. Please go ahead. Yeah.
Yeah. So I think we investigated this case and we felt that it was unduly delayed, the management. So although we do appear probably a bit more resource rich country, but it is taxpayers funded, so we do have to justify we are not overdoing things as well. But I think the main worry what people were having was that are they gonna take this patient who then has a malignancy and they end up just opening the cyst and increasing the staging of it. So that was what was holding people back. That is why they had put her for MDT. Now MDT happens once a week, which is why it gets so delayed. So maybe we need to look into, just ring and call expert to look into it rather than keep waiting for that opinion. And think with regards to, she was always going to need surgery. There's no doubt, because she is chronic ectopic, and that was the way forward. And I think it was just the matter of, okay, am I gonna be penalized if it's a cancer? She's only 28-year-old and we make it stage 3 tomorrow. So that was what was the issue. That's why they got delayed. And I think, yeah, I mean, the oral iron, I think because the hemoglobin was 77, we would give, because that is anemia anyways. But if it was acute unwell patient, then yes, it is not, oral iron is not gonna solve the issue. And often people do things because they feel like they have to do something, even if it is not gonna be meaningful. So that is where this all went. I'll pass on to Abha.
Now, before you make the final comment, may I ask one thing? Now, what actually you were expecting in waiting for 7 days? What was your plan of treatment, the final treatment?
basically for 7 days, how the service is run is there is a different on-call person every day. So this is where if it was one person managed through, then things would probably be different. Every day person will hand over to next and then to next. So things go on like that. And first person decided we'll wait for MDT, then everybody else just waited for MDT. And I don't see a point when MRI concluded it doesn't look malignant, it looks ectopic, then there shouldn't have been more delay. So maybe even if we didn't take her day 1, we should have taken her day 3 at least.
Right.
What happens in India, the patient party will eat your head until and unless you do the surgery.
Yeah.
If they collapse at home, all hell broke loose. So, I mean, we are having different resource problems. Yeah. Right. So, Abha, you want to say something, or you can show the second case?
Yeah, I would like to say that.
Abha. आवाज नहीं आ रहा. Abha, हाँ.
How this all evolved and this passing on, and one person put this doubt of MDT, and then it kept on going on the spanner of possible gynecological malignancy rather than thinking simple things are simple. So, and then it was sort of delayed, and that is why we brought this case to this forum. But happens easily and all done and dusted, doesn't need presenting because that's very simple. And these are the cases where we have to learn. And looking back, everyone is very clever retrospectively. So I have got 2 cases, but I will present the one which is very much similar to this case. And I want to present it as a diagnostic conundrum or diagnostic dilemma in adnexal mass, diagnosis of adnexal mass with a positive HCG. So I will jump my first case. I'll try to share the screen. And that was I think I will. Just 1 second.
Yeah.
So I'll go to the second case first. Sorry, I'm flicking all the slides.
We can't see your slides, Dipti. You have to start sharing your screen. It seems you have not started. Yeah.
Is it not? Okay. Go back to system. No problem. Now select one.
Can you all see?
Yeah, it is showing. Yeah, we can see. Make it slideshow.
So this is again a diagnostic dilemma of adnexal mass with positive.
Sorry to interfere. Please make it slideshow. It is not in slideshow. Fantastic.
Yeah. So a very similar case. That's why we both chose these cases to show that how different things can be found on such cases. So this was managed by me in my hospital. So this is a 28-year-old again who has a first normal vaginal birth, completely fit and well lady with normal BMI, normal smear history. Came in over the weekend with 9 weeks amenorrhea and history of pain and spotting. That is what brought her in. She was clinically stable and well. Pain, abdominal pain and spotting. When she was admitted, she had stable vital signs. She had tenderness in her right iliac fossa. So the first line investigation was done. Her blood count was normal, hemoglobin stable. HCG was reported as 550. And then she had a scan which showed a complex adnexal mass 7 by 5 centimeter with a tubular mass 77 by 28 millimeter. So the doctors who reviewed her on the weekend made a plan to repeat the HCG in 48 hours. So I have put that value on this same slide, and that was 489. So far, everyone okay? Any questions? Would you do anything different? Because they were not sure about this nature of mass and ectopic pregnancy, and they were all thinking in lines of MRI. So what happens is next day, I reviewed this patient myself, and I had a full discussion with her. And I told her that, look, we need to take you to theater. I don't know what MRI is going to add. you have a collage complex and neck cell mass. I have the privilege and advantage of having the Pan Birmingham gynae oncologist at my site. So someone can join me, which many units in Birmingham do not have. So I was like, okay, let's take you to theater. Whatever we find, I will get the right people involved. So we went in. She agreed with a bit of reluctance because she was well, and it was an uneventful laparoscopy. Her both tubes were normal. Her left ovary was normal. Her right ovary was a complex mass, multilocular with free fluid. So got the gynae oncology second opinion and proceeded with right salpingo-oophorectomy, laparoscopic right salpingo-oophorectomy with peritoneal washing and omental biopsy. And lo and behold, this patient was diagnosed with a dysgerminoma of right ovary. And the omental biopsy showed atypical cells as well. So she's currently under the gynae oncology center. They have arranged a CT scan, CT thorax, abdomen, and pelvis. This case has happened only 2 weeks ago. And she has been referred to Charing Cross for adjuvant chemotherapy. As you may know, that Charing Cross is the center in the UK for our region, Birmingham and below, south, for all these germ cell tumor management and trophoblastic diseases. So shall we discuss this case before we proceed to another case?
Yeah. Dr. Shamal, I can see you. Your comments? Yeah.
One thing I am very surprised. Why omental biopsy had to be taken? Just because it was an ovarian mass?
Yes.
Now, why you people didn't think that it could be an ovarian ectopic pregnancy?
Well, we weren't sure what was happening. It looked like a ovarian tumor. I have myself done this case, and it was multiloculated. Part of it appeared cystic, but very thick walled. Part of it was solid, and that's our standard protocol of a staging laparotomy or laparoscopy in this case, that you will do omental biopsy and peritoneal washing.
I believe you people are very much. You have seen many more cases like this before as well. Otherwise, simply we would have gone for oophorectomy or salpingo-oophorectomy and not bothering to do a omental biopsy.
I have to interfere here, Abha. To be very honest, all ovarian suspected tumor must have an omental biopsy peritoneal washing, so it can be graded. And that is the FIGO guidelines, and that is the cancer oncology guidelines. So
absolutely right.
Suspected tumor.
What I wanted to mean, madam, usually with a beta ECG high, just being positive, suspecting a kind of ectopic pregnancy, either chronic ectopic or ruptured and hematoma formed there, maybe an ovarian ectopic pregnancy because tube is normal. So what we usually intend to do is remove the ovary or the mass itself, send it for histopathology, and usually I think it won't come to the mind of day-to-day surgeons to take a piece of momentum. That's great. Fantastic.
No, I agree. I totally agree. But I think they have a luxury of gynae oncology with them.
Exactly.
So
you people are always an oncology-minded surgeon.
No, not necessary. They have picked up unusual cases which have thrown them away. So it's about a learning, so they can bring all usual cases and all of us can be happy about it. But they have specifically picked the unusual cases and they were suspicious of something not right. So they included the oncology team because you have a team there. Why not? And they opened the patient, and on the table, I can call my oncology who is possibly around somewhere. So they didn't plan to begin. Yeah.
So basically, when you do the laparoscopy, chronic ectopic, you know that it will be bluish, congested, red, there will be hemorrhage, there will be adhesion. This was a solid mass floating around, so it is not an ectopic by any means.
Yeah, Abha, all I'm trying to say here is, you need to imagine a scenario where we are in the main theaters and 10 more theaters are working around us. And one of the theater will have gynae oncologist or a surgeon. So we have a luxury to call them in to have a look. And when they look and when they feel suspicious, they give us some advice. So we are talking from a very different perspective here. We have the floor with 10 theaters running with all sorts of multi-faculty going around. And we are in a place where we can call for help if we are worried about the patient. And that's what happened here. Am I right, Abha?
Madam,
Yeah,
come
yeah.
back to our
Well
country.
So,
Well said,
When
Jyotika.
of new setups like this, we want to work in such an environment.
I
Just
know,
like
but
We need doctors. Come, Dr. Sid.
Let
Can
us
I-
have, let us
can I
have
ask one
opinion of
question?
Dr. Rujuta. She is in the teaching hospital. Yeah, Rujuta, what you would have done in your teaching place? Yeah.
Ma'am, yeah, what I want to say is 2 points I want to stress upon. First of all, chronic ectopic can be very, very confusing. It can have adhesions, it can look like malignancy. We all know many a times we have done cases where we have just opened the abdomen and we have closed it because of the dense adhesions, or maybe we're not able to proceed with the procedure. Another thing is, if it is suspicious of malignancy, then we can have frozen sections. We can then and there only remove a tissue, go for frozen section, have the histopath there only, and we can then proceed or decide whether we have to go for omentectomy or omental biopsy or not. So that if we have that facility with us, then definitely we should opt for that facility of frozen section. So
Doctor-
having they say you should be ectopic minded. I think you should be oncology minded also in this case. But at the same time, if we have this facility, we sure could go with it.
Yes, Dr.
Ma'am,
Kishore, yes.
Dr. Lakshmi?
Yes, sir,
Doctor,
आप बोलिए.
Can I
Yes,
can I
yes,
put in?
आप ही बोलिए अभी आप.
First thing, the first principle of anything in medicine is to make a diagnosis before you do management. So, what was the diagnosis? What was the diagnosis or the differential diagnosis first? If it was a chronic ectopic or it was a malignancy, whatever, but you were not sure what was it. Therefore, and there was no urgency to start the management. You could have done investigations for this patient to know exactly whether it is malignancy or it is chronic ectopic. Before that, and you started managing before making a proper diagnosis, and then after that, management was perfect because you had you diagnosed it after opening that it was not ectopic and it was a dysgerminoma, and therefore management was perfect. But in my opinion, this management should have waited with investigations, because unless there was an emergency, I don't know what were the clinical findings that the ectopic and kholna hai, but this is what I think.
I beg to differ, sir. Even in our Indian setup, if we put on a scope and find that this is not a chronic ectopic, rather an ovarian tumor, we cannot wait for the management or for the final diagnosis. We'll have to.
No, I'm not saying. I am saying before. I'm asking before you take up the case. Once you take up the case, there is a
done with a provisional diagnosis of chronic ectopic.
That is what
But
I'm saying.
incidentally, it was found the tubes are healthy. Other sided ovary was healthy. Only this ovary has got this kind of tumor. So it has to be treated. It needed to be treated then and then. So you cannot wait. There is no question of wait and watch for this case. I think whatever has been done, perfect.
Yes.
But then the question arises whether we had already taken consent of removing ovary and tubes, because that is the main
consent. And there was
I believe if you remove something pathological, you do not need to have a separate consent. If you remove
this patient was consented for oophorectomy because we told her
that
chronic ectopic, it could be an ovarian tumor. And on the consent, we have always a line that do as necessary to deal with unexpected findings. We always write this. And if you are doing something which was not, you always get a second opinion and two consultants agree. You don't want to wake her up and tell her, oh, you have ovarian tumor, tomorrow we will do an operation.
Right.
Yeah, because the RCOG guidelines, it clearly mentions if you find out some other pathology, if you have not taken consent, you cannot just go and remove ovaries or tubes of that patient, even if you see the pathology there. But it's a RCOG guideline, I think. Right?
No, it is their guidelines, but in Indian setting, I think if we are not taken consent, we do inform the relatives and we do take their consent, because we just can't close it up and then call her for further. So we can take the consent of relatives and then we can go ahead. Yes, sir.
I agree with Dr. Rujuta, but if you want to remove one ovary, which is obviously pathological in front of your eyes,
Yeah.
you can go for removal. Just inform the patient party. It's not required that you need a consent to remove.
Or inform prior. So this can happen, and we may have to remove your ovaries. That is the consent part is important. What I mean to say.
Yeah. You highlighted that part because we are all living in the medical legal era. So that is very, very important. Yes, Dipti and then Abha. Yeah.
We're going to say that, yeah, I mean, for chronic ectopic, we would expect an expert. Can you not hear? For the because it is a chronic ectopic, we already knew from imaging that it was complex. So all these we would consent, but occasionally you could get out, caught out. You haven't consented, during elective cesarean, you find unexpected, and that time, I mean, we have luxury that it will be spinal and patient will be awake. But in patient's best interest, if we have missed things, then we can get another consultant to agree, and we can proceed in patient's best interest and see. I think important message from this case was that we went in with chronic ectopic, and if diagnosis looked not ectopic and malignant, then doing the mental biopsy saved patient to come back for just that, because her staging happened and now she doesn't need another operation. She'll be managed accordingly. So I think it will be good to bear that in mind. If we find something unusual, then consider doing the washings and consider that, so that we've done the staging process in that operation rather than bringing patient back for that.
Yes, very well managed. Yeah, Dipti, we will proceed with the third case.
Okay, so let me share screen.
Did you press share there? Yeah.
So this is a case also which went on for a few days. So that's why I have brought it here, and we will have points of discussion. So this patient presented to our accident and emergency department on the 8th of October, because again, the time is important. She went on for 4 weeks, and that is why I have brought her here for discussion. So she had a history of abdominal pain, bloating, diarrhea, and vomiting. Previous medical history of hypothyroidism, asthma, no allergies. She has been on levothyroxine, salbutamol, and was on progesterone, prednisolone, and enoxaparin. So the next line explains that she is a primate who is undergoing IVF. She had her egg collection on the 22nd of September, and then implantation on 27th September. So she comes to our hospital on the 8th of October with a positive urine pregnancy test, with abdominal pain, bloating, diarrhea, and vomiting. What would you think to the panel? Let's go slide by slide, some questions and interactive discussion here.
Yeah, I can see Rujuta. Rujuta, you can start.
Yeah, so a patient who has just undergone IVF and whose UPT is positive, and she comes with abdominal pain, bloating, diarrhea, and vomiting, right? Yes. Hello, am I audible?
Yes.
Yeah. Rujuta, you are audible.
Yeah, so all gynec first trimester pregnancy complications should at once come to our mind, including threatened abortion, miscarriages, or maybe pregnancy, ectopic pregnancies. So with all these diseases, we should proceed with the investigations, and we should investigate the patient on these lines. Additionally, we should also think of some other surgical problems associated with the early pregnancy. So it can be where exactly she is having abdominal pain, what is the location of the pain, and associated symptoms will definitely guide us. So first thing should be early pregnancy complications. In additionally, we should also suspect her for the surgical problems as well, like the appendicitis, or if she's having some ovarian enlarged ovaries. So it was that ovarian torsion, and
she was undergoing IVF, so you can think of worry about ovarian hyperstimulation here as well.
And okay, hyperstimulation can be another differential diagnosis in this patient.
But Dipti, nowadays every IVF center tries their level best, because we all are OHSS free clinic. I mean, to be frank, in India, I mean, we try to avoid OHSS with the antagonist protocol and the agonist trigger and freeze all embryo policy.
Okay.
Yeah.
So, okay, let's go to the next slide.
Yeah.
So when she was examined, abdomen was distended, but it was soft. Vulva, vagina, speculum was normal, no bleeding. On bimanual also, no much excitation or pain. So she had the investigations, the basic observations looked all stable. Blood tests, hemoglobin is 161. Her white cell count was raised, 30. In the UK, the cutoff is 11.5. And her hematocrit was also slightly high. The transvaginal scan showed a small cystic area within the endometrium with a query of a gestational sac, only 2 millimeter though. On the right ovary, there was a cystic area in the ovary measuring 27 by 23 millimeters, suggestive of an endometrioma, a small mass. Carry on.
Yeah, Dr. Shamal.
Can I have a beta ECG value?
Yeah.
Yeah, let's go. Next slide may tell us the HCG value. So yes, she was managed as ovarian hyperstimulation, and the HCG value was 112.
Yeah, this is a case of ovarian hyperstimulation. Yeah.
Okay, so she was still complaining of pain, bloating.
Conservative line.
So she was discharged home as her symptoms sort of slightly settled next day.
Yeah.
So she came back 2 days later. And now that she was brought back to repeat the HCG. So it is 449. So it has gone up more than double. And then the plan was to repeat her scan in 10 days to allow this pregnancy wherever it is, because she, I mean, she was clinically all right. So when then she had the scan on 21st of October, that cystic area in the uterus and the gestational sac was not seen. So on the right ovary, there is again a hemorrhagic cyst, 32 by 26 millimeter with some free fluid. So she was also under the IVF clinic. IVF clinic is not in the same hospital. So the HCG was done at the IVF clinic and it was more than 1,000. But that's a bit worrying, isn't it? 10 days later, it's only more than 1,000. And it was nearly 450 on the 11th.
Pregnancy of unknown location. We can.
Yes. But there is a hemorrhagic cyst in that right ovarian adnexal region, what that is. Anyway, so she wanted to continue her IVF care and follow up there. And she said she will ring us if there was any emergency. So IVF, just to update you, like in the UK, mostly IVF clinics are separate fertility clinics. It's not within the acute hospital. So they just manage the IVF part and it is just elective work. If the patient has a complication, miscarriage, ectopic pain, they have to report to the nearest acute hospital, emergency department or early pregnancy unit. So they don't manage that side of things. So it's sort of more like semi-privatized IVF here. So then she attends 6 days later with abdominal pain, bloating and shortness of breath with some spotting. The urine pregnancy test was done in the emergency department, which was positive. So there was still generalized tenderness, distended abdomen. What are we thinking? We are like 20 days later presentation. Any comments?
Rujita, you want to say?
Yeah, I think we are dealing with pregnancy of unknown location or ectopic pregnancy. I mean,
So-
on that line.
So again, her observations look pretty stable. The heart rate was slightly high. And the hemoglobin, which was 160 before, isn't it, is now 110. White cell count, lactates, she had the whole, you know, a junior doctor sees her and does on her done. So this is the current status. So now the diagnosis here is a late onset ovarian hyperstimulation syndrome. She was admitted with the usual protocol of management for thromboprophylaxis, daily girth, ultrasound to be done next day, the U's&E's, LFTs. HCG was done. So IVF clinic on the 26th of October was 2040 and it was now done 1976. So we are dealing with like a static or a plateau in the HCG now. Clearly not a viable pregnancy by the looks of it.
Right.
Any thoughts here?
Dr. Shamal said, you want to say something? Yeah.
I am just watching where is the location of the pregnancy, if at all.
So next day, she had a scan.
Teachers were suggesting ovarian hyperstimulation syndrome, no doubt about that.
So next day, she had a scan. So scan is showing now a mixed echo area in the on Doppler in endometrial cavity, querimolar.
Yeah.
And there is this complex cystic mass outside as well.
It's there.
So the right ovarian, this whatever hemorrhagic cyst, got whatever, you know, is going on from the beginning. And now there is something in the uterus, HCG 1764. So it's like very plateau. Then at this point, someone decided to do an evacuation for her. So she was consented for this evac. So on that day, the theater, apparently the emergency theater was very busy. So the evac could not be done. Her hemoglobin is also gradually going down, as you can see, from 160 to 96. Anyway, I mean, I wasn't present. I was in India at this time for Diwali in October. So I did not witness this case. And the HCG is now all like plateau between 1900, 1700. She had the evac done and there were a lot of products removed. Any thoughts?
Dr. Sharma?
I think histopathological report of the products will confirm.
Yeah, we will see. Yeah, we'll carry on. So next day, the patient was there. She's still bloated, struggling with pain. Hemoglobin is sort of pretty stable. Again had a scan, and now this mass in the right side is slightly bigger, 6 by 6 centimeter. It was, remember, 35 by 40, 3 to 4 centimeters, unchanged. And then people are thinking, could it be ectopic? Unlikely, but this has been present for the last 20 days. But to keep the patient in the hospital, they didn't discharge her.
I think the increase in size of the ovarian cyst is because of increased level of beta HCG. Because the hemorrhagic remains of the same size.
So this is her HCG graph. It went up to about 2000 and then it's like plateau between 17 to 19.
Now it starts getting down. Yeah.
So you think that the evacuation was done and the HCG is going down now? It's not going down that significantly.
Yeah, it's like
yes, it's going down a little bit.
Plateau actually.
Thyroid function tests and X-ray chest.
I don't know whether it was done, but I presume that it wasn't done.
Okay.
So now at this point, the on-call doctor decided to go to theater to know what's going on, and they found a right-sided ectopic pregnancy with 500 mils of clot in the pelvis.
So it was ectopic pregnancy.
It was ectopic. So I think there are a few more slides. Let's have a look. So what we sort of, you know, when you review a case, you look at what was the good parts of the care. She was kept under surveillance. She was diagnosed to have ovarian hyperstimulation, which was managed well. Whenever she was discharged, she was told that we are not sure what's going on. Problem just keep coming back. The discussion point is, should we have considered ectopic sooner?
No, actually not. The features were not suggestive of ectopic, and very rarely we do consider of heterotopic kind of pregnancy. If you see query-molar pregnancy in the uterine cavity, although it can happen in IVF, post-IVF pregnancies, very common heterotopic pregnancy. I've seen a few cases. The other one getting ruptured and the intrauterine pregnancy going on fine.
Going on.
So yes, if you have got that thing in your mind, you should have had this doubt in your mind that it may be ectopic vis-a-vis intrauterine, say, molar pregnancy or whatever.
So yeah, that was the points we said, that this mass was visible, but reported sometimes as endometrioma, sometimes as hemorrhagic cyst. That is why I said the quality of scan, the experience of the operator is very important. She was in significant pain, which was generally not a symptom of OHSS, and the beta HCG was showing suboptimal fall. So should we have done a laparoscopy sooner? There was a case report about late onset ovarian hyperstimulation and severe hyperstimulation coexisting with bilateral ectopic. So, the team looked into all this. This is post-laparoscopy, obviously. Should molar pregnancy been considered and treated for? HCG levels were highest was only 1900. Our hands were tied by ultrasound. Very low chance of molar following IVF. Yeah, she had an evac 2 procedures. So hydatiform mole, they looked into some piece of literature. So the use of ICSI is protective against triploidy. However, the retrospective data suggests that it cannot be eliminated with the use of ART.
Yeah.
So yeah, this was the interesting case. I have already presented this case. So
Yeah. Thank you. And Rujuta, Shamal, Dr. Shamal, you have any comments?
This is
Or
a
take
very
home
rare
message
kind of
on
case.
all the 3 cases to our audience, the practical take home messages.
The first one was fine. That's what is. The second one was unique because you people are working in gynae oncology department. So fantastic. And the third case is really it's unique. I have never heard of. Forget about what I have seen in my own practice. I've never heard of that. One pregnancy is possibly hydatiform mole. Other one is ectopic.
Yeah.
Post IVF. Great. I don't know. If we see sometime in our own practice where we are going to end with the patient. And
so we say in Birmingham that what you never see anywhere in your lifetime, you will see in City Hospital, Birmingham. That's where I work. So this is our standard saying. So when you come to obstetrics and gynae, just from the day one as you enter, when I first joined there 15 years ago, one of the registrars who was there, I started as a consultant. He told me, Mrs. Sinha, यहाँ आते हैं ना तो बाहर ही बोलते हैं कि जय हनुमान और उधर उसके बाद घुसते हैं लेबर वार्ड में. ऐसे ही होता है इधर. तो
problem is the only pain and thinking it on the line of an ectopic pregnancy. Gone are the days. So you should have to conclude your diagnosis with many other parameters. And to be very honest, initially those features were not going in the line of ectopic pregnancy. And you should depend on the sonologist also. If he says it's an hemorrhagic cyst and not growing, not increasing in the size, unless the last sonography which showed the size of the ovary itself, not the cyst itself. Only the ovarian mass volume increased, but the cyst size remains same. But anything can happen. Yes, obstetrics is like that only.
Rujuta, your take home message for our audience.
Yeah. We should be ectopic minded. There is no doubt about it. But in addition to that, now I am feeling we should be oncology minded also. So a patient can present with anything like a malignancy or maybe a neoplasm. So we should actually think on those lines also. This is the take-home message, I think.
Yeah. Dipti, your take-home message, then Abha will give her concluding remarks. And then Jyoti will propose official vote of thanks.
I feel from this case, it particularly elaborates that when things are looking a little bit different, then not to just give up with initial diagnosis, always review. Like they had done the evac, but there was some inkling that mass is something. She could have easily been discharged and left and came with rupture, but they followed that mass and picked it up. So I think that will be important to make sure if things are not fitting perfectly, review, reconsider and revisit your decision.
Fantastic. Those 3 cases, Dipti, your selection of cases, your management and discussion was simply superb. And I think our audience must have been benefited that we have to think so many aspects as Dr. Rujuta and Dr. Shamal has said. Yes, you have to be ectopic minded, but now in this era of IVF and CA ovary rising up, we have to think of many more differential diagnoses.
Thank you.
Yeah. And I believe you people are having more difficult cases with you. You didn't just present that we won't be able to cope up with your cases.
Very busy units with serving a variety of, I think the ethnicity is so broad that, that the challenges are just beyond compare. Right from language barriers to patient beliefs who will not accept treatment. They will not have a cesarean section and watch their baby die also happens. So we always have to be very open-minded. And what I will say is always ask for help. Always discuss with your colleagues.
Yes.
Phone a friend is very, very important to deliver a safe and effective care and save women's lives.
Dr. Lakshmi, I just wanted to add something.
Yeah, please.
Abha and Deepti, thank you so much for bringing these controversial cases.
Yes.
We just wanted to showcase that things always don't go right, whether you're in UK or London or in India. Sometimes they go wrong. And it's about learning from the mistakes of others. And hats off to both of you to bring such complicated cases where you try to learn yourself and we are trying to discuss the same. And thanks a lot for sparing your time in such a beautiful, lovely summer sunny day in UK today.
Exactly. We are out in the garden now.
With a glass of wine, I'm sure. Thank you all the faculty and the panelists, because your input is so vital for us to learn as well, because you have humongous experience behind you as well. So I hope this has at least raised some awareness and thought process for the future.
Well said, Jyotsna. It has. And yeah, Abha, you are our international convener. You want to give any concluding remarks?
No, I just
the whole webinar theme, early pregnancy problems.
So I just want to thank everybody who participated and contributed with their ideas and suggestions. Thanks to Dipti and Jyotsna, who gave us this platform to come and share our thoughts, and all of you, all our panelists, all those brilliant people who sort of contributed. So yeah, early pregnancy is an important area, and as we have now seen that it is just not very simple. The simple cases we didn't want to bring, so it can be complicated. So we have to keep our antennas in all direction. And as I said, take the advice, discuss your cases, phone a friend. Now in the days of all this media and WhatsApp, you can easily share. I mean, in UK, we are not allowed to share patient information over any of this, but you can always phone a friend and discuss a case. And there are specialist centers. There are people who with special interests in early pregnancy problems. And yeah, so just be open and always learn and reflect and learn from every case and share it with others for their learning. And yeah, that's what I have to say. Thank you, everybody.
Thank you, Dipti. Thank you, Abha. Thank you, Jyotsna. It was a wonderful interaction. So now I hand over back to Dr. Jyoti for formal vote of thanks.
Thank you so much. Thank you, our foreign faculty, for bringing on such interesting and such mind-blowing cases. I mean, it was amazing. Even we could never ever have thought of such cases. I mean, next time when a pregnancy of unknown location comes, we'll start, I mean, our antennas will be all up now. So thank you so much. It was wonderful. Thank you, Dr. Jyotsna, for giving us this beautiful platform where we can sort of cross-exchange these thoughts over the borders. We can understand what you people are doing, your evidences, guidelines, and our experiences and guidelines as well. So it is a great interactive platform where which Dr. Lakshmi has created for us and Dr. Jyotsna has given us. So wonderful, wonderful. And for taking out time on a Saturday morning for all of us, it is worth thanking you all from the core of our heart. And our other Indian faculty, not to miss all our chairpersons, Dr. Vijay Lakshmi, Dr. Sampath Kumari, Dr. Gokul Chandradas, and then our panelist, Dr. Parikshit Tank was held up in an obstetric emergency, and he's sent his regrets, and he was, I mean, that is why he could not join us. Dr. Shamal Said, Dr. Rujuta, and Dr. Kishore. I mean, your inputs have been absolutely great, very practical, and very, very informative. And then I think, thank you all our participants who had logged in today for this. Looked like a simple topic, but very, very important and very, very practical topic for each and every obstetrician actually. And thank you, Dr. Lakshmi ma'am, for everything. Thank you, Dr. Vishal and Walter Bushnell. So I hope we all enjoyed it, and thank you with a great, big, good luck and lots of love. Thank you.
Thank you, ma'am.
Thank you, Jyoti, for wonderful moderation and being one of the conveners for this Indo-International web series. Thank you all. Dipti, Abha, please stay connected.
Yes.
We'll stay in touch. See you more often.
We had lovely time.
Shyamala,
Thank you.
Rujita. Bye. See you all
Bye-bye.
soon.
Bye.
Bye.
Bye, everyone.
Bye.